Our team has nothing to disclose. Our patient is a 55-year-old right-hand dominant laborer who presents with a 2-year history of recently exacerbated right shoulder pain and weakness. He has guarded forward elevation to 40 degrees. He has weakness on the Job's test, resisted external rotation, as well as a positive belly press sign. X-ray imaging of the right shoulder does not identify any significant glenohumeral arthritis. There is mild elevation of the humeral head, as well as some mild calcifications in the rotator cuff. MRI imaging of the right shoulder does identify a large rotator cuff tear with retraction. There is evidence of biceps subluxation and a subscapularis tear, as well as fatty infiltration of the supraspinatus and infraspinatus muscle bellies. This patient was taken to the operating room and placed in beach chair position. Standard portal incisions were made on the right shoulder, and a systematic inspection of the glenohumeral joint was performed. The subscapularis tendon was addressed initially and repaired arthroscopically in an antegrade fashion using 2 bone anchors. Here is the repair completed and moving as a unit with the humeral head. In the subacromial space, a large rotator cuff tear is identified without adequate mobilization to the footprint. That footprint is then debrided down to healthy bleeding bone. An anterior slide was performed to release adhesions that are restricting the mobility of the rotator cuff. Next, 3 lasso loops using fiber-link suture are passed into the intra-articular long head of the biceps tendon with a low-profile scorpion suture passer. Once the suture lasso loops have been placed into the long head of the biceps tendon, the distal remaining portion is tenotomized. This allows the bicep tendon to swing over and become anchored into the greater tuberosity, with the shoulder in approximately 30 degrees of forward flexion and 30 degrees of abduction. A 5.5 biocomposite swivel lock anchor is used for the humeral side. Next, repair of the infraspinatus onto the posterior greater tuberosity footprint is performed with anchor placement with concomitant side-to-side soft tissue repair to the posterior edge of the long head of the biceps tendon. Any remaining supraspinatus anterior to the biceps is mobilized by performing an anterior interval slide in continuity. By allowing further lateral excursion, the supraspinatus can be anchored into the anterior footprint of the greater tuberosity. A concomitant side-to-side repair to the anterior border of the long head of the biceps may be done as well. Full coverage of the humeral head can be achieved without placing the cuff repair on supraphysiologic tension. A crimson duvet technique is also used to improve biology in the area of repair. Shown here is placement of the second rotator cuff anchor. And this is a view of the final repair. Full coverage of the humeral head can be achieved without placing the cuff repair on significant stress using this technique. At 1 year follow-up, the patient has no pain and improved range of motion of his shoulder. At 2 years follow-up, he still has no pain and has increased strength and range of motion of his right shoulder and feels that it is functioning at 95% of his left.